Now let us learn about scalp. Scalp is very important for us to know, not just to pass the exam, but also when you are working in the trauma department. When you are working in the trauma department and the patients come to you with the head injury, so there is suturing of the scalp that is being done. So when you are aware of scalp in detail, then only you will be able to appreciate, okay, what is the procedure that's being done over the patients. Are you understanding? So that we are going to learn. So now let us start defining the scalp. What is scalp? Scalp is a soft tissue which covers the calvarium of the skull. The scalp is a soft tissue which covers the calvarium of the skull. Now what is calvarium? Calvarium is nothing but the skull cap. Now you know in the anatomy department you must be seeing cranium, and the upper portion of the cranium is being cut and you can remove the upper convex dome, and then that is called calvarium or the skull cap. Now what is the difference between cranium and a skull? To the cranium, when there is mandible attached or when you present the cranium with mandible, then it is called skull. But if you remove the mandible, then it is called cranium. This cranium, when you cut in such a style above the eyebrows or above the superciliary arches, you know, the transverse section when you make, what you get into your hand, this upper portion is called the calvarium or the skull cap. Okay, so the soft tissue which covers the calvarium of the skull is called the scalp. Now let us go with the extent of the scalp. Anteriorly, the scalp is extending up to the level of eyebrows or the superciliary arches. Posteriorly, it is extending up to the level of external occipital protuberance and the superior nuchal lines which are diverging from the external occipital protuberance. Anteriorly, the superciliary arches or the eyebrows are forming the anterior limits of the scalp. Posteriorly, the external occipital protuberance with the superior nuchal lines. On either side, the scalp extends up to the level of zygomatic arches involving the temporal regions. On either side, it is extending to the level of zygomatic arches involving the temporal regions. Okay. Now let us learn about the scalp, which is made up of basically 5 layers. That is the skin, connective tissue, aponeurosis, loose area tissue, and the pericranium. Okay, these are the 5 layers. Now before we start learning the 5 layers of the scalp, just let us try to understand the cranial cavity. Now you know I am trying to draw the cranial cavity, you know, that calvarium bone I am trying to draw, not the cavity, the part of a cranial cavity. Now what you are seeing here is the outer table of the skull. What you are seeing here is the inner table of the skull. In between the outer and inner table of the skull, what you are having? You are having diploe. You are having diploe present between the outer and inner table of the skull. Now here you have got the sutures, okay, and this is the endosteal layer of the dura mater. We said the cranial dura is made up of 2 layers, outer endosteal layer and inner meningeal layer. So here we are having the endosteal layer of dura mater, which is also called as endocranium or the endosteal layer of dura mater, which is forming the endocranium. And here you have got the meningeal layer, and between them, you know, you have got the sinus. Now here what you are having is the sinus that is filled up by the venous blood. So this is the sinus. Are you able to appreciate what I am trying to draw? Okay. Now let us, now we said the connective tissue which is covering this cranial vault or the calvarium is called the scalp. So now let us learn about it. Now first let us go with the skin of the scalp. So if you are talking about the skin of the scalp, you know the skin, here I am trying to draw the skin, shows lots of hairs. It is showing lots of hairs. Lots of means how many? Maybe 1,20,000 to 1,30,000 of hairs it is having. And it is having lots of sweat glands and sebaceous glands. it is having hairs, it is having sweat glands and sebaceous glands. Because of so many sebaceous glands, it is a common site of sebaceous cyst to form. Now you know there is an upcoming specialty. What is that? About the hairs? Trichology. So trichology is study of the hairs in detail. Okay. And now the trichologists, they are earning a lot. Okay. If you look at the hairs, they give an index about the nutritional status of a person, because there are diseases called or protein energy malnutrition. There are protein energy malnutrition states which are called marasmus and kwashiorkor, where the hairs are dirty brown in color. The hairs, they are dirty brown in color, and you have got flag sign and all. In detail you will be learning, but just try to understand. Looking at the hairs also you can tell the nutritional status of the person. And you know, hairs are basically formed by protein, keratin. Okay, so if you want nice hairs, then you should eat good amount of protein in your diet. Then it is the common site of sebaceous cysts, because there are lots of sebaceous glands. And normally per day we lose about 10 to 20 to up to 100 hair follicles you can lose. Daily if you are losing 10 to 100 hair follicles, it is normal, because there is concomitant replacement of this lost hair. There is concomitant replacement of this lost hair. So even if this hair is lost, it is replaced by the new hair. But more than this, if you are losing, then again you have to consult the dermatologist or the trichologist, take their opinion. Are you understanding? And please see, there is a condition called baldness, which is especially seen in case of men. And sometimes it is understood that baldness is because of genetic influence. The father is baldy, then the son also can become baldy at a very young age. You are understanding? And in women, there can be baldness seen especially after their menopausal age, maybe at the age of 60, 65. The density of the hairs in women will be less, and they can also present with the relatively, they can be baldy from what they were when they were young. Okay, so age matters for your looks. Then after the skin, you have got the connective tissue. The connective tissue is a fibrofatty stroma that is present here. So the connective tissue is nothing but the fibrofatty stroma what you are having. Please note, the blood vessels which are present in this area, that is the second layer in the connective tissue, they are very much attached to these fibrous strands that are present in the connective tissue. So the arteries and veins, they are very much attached to these fibrous strands. So what is the importance? Imagine if there is any injury to the scalp, if there is any cut in the scalp, it is bleeding, and it is bleeding enormously. Profusely it is bleeding, because the blood vessels are not in a capacity to retract. The blood vessels cannot retract because of their attachment to this fibrous strand. Okay, so how will you control the bleeding now when somebody is having a scalp injury and blood is lost? How will you do? There is a profuse scalp hemorrhage. What do you do? With the tips of the fingers, if you just compress with the tips of the of your fingers, if you just press upon the skull, okay, if you are just pressing, automatically the bleeding will stop. It is like magic. Now you will not have any blood coming out if you press with the tips of your fingers. Otherwise, it is going on oozing and oozing and oozing. Or what you can do is, above the eyebrows and above the ear, you will have to tie a tight bandage with pads of cotton, you know, very tightly. When this is called a pressure bandage, you can even tell. So if you do that bandaging to the scalp, again the bleeding will be very much reduced. Otherwise it will be bleeding like that non-stop. In case of children, imagine there is a baby which is on the crib or whatever cot, and it had fallen down, it had got head injury. It will be bleeding so much. By the time you take the baby to the hospital, there is a the baby is in a shock, or even there can be death occurring because of loss of blood. So be very careful. Just by application of pressure, you can save somebody's life by preventing the blood loss. Okay, application pressure is the key of the treatment. Then you have got the third layer, which is called the epicranial aponeurosis. So here you have got the third layer, which is called epicranial aponeurosis. Okay, this is the epicranial aponeurosis, or it is also called galea aponeurotica. It is also called galea aponeurotica. Now, what do you mean by galea in Latin? Galea in Latin means helmet. It is meaning helmet in Latin. Now, if you see, I have made it very thick, the galea aponeurotica. Anteriorly, you have got a muscle that is called frontalis, and posteriorly you have got a muscle and that is called occipitalis for the galea aponeurotica. Are you understanding? Covering the cranial vault, you have got the galea aponeurotica. Anteriorly you have got the frontalis muscle, and posteriorly you have got the occipital bellies, that we are going to learn in detail. And please look at the beauty of the scalp. These three layers, that is the skin, the connective tissue and the epicranial aponeurosis, they move as if they are one layer. So it is also called as scalp proper, or it is also called as the surgical layers of scalp. These are called the surgical layers of scalp. You're understanding? The 1, 2, 3 layers. Now let us just try to draw the head of the person. Okay, now you are standing at the head end of the table. Now you know a person is lying down, he is lying supine. Now you go back at its head, you remove the pillow from the person's head, below the person's head. Now you remove the pillow and you go and stand behind him. Then you are seeing what? You are seeing like this. Okay, so here, this is the nose. Okay, these are the ears, what you are seeing. Now here you are having the epicranial aponeurosis. So this is the epicranial aponeurosis which is present. Okay, now from where to where is this epicranial aponeurosis extending? We will learn. Then what did I said? This galea aponeurotica, which is also called epicranial aponeurosis, is having what? It is having anteriorly the frontal bellies. Are you understanding? There are the frontal bellies, what it's having anteriorly, and posteriorly it is having occipital bellies. So here what you have is the occipital bellies, the muscle, okay, occipital bellies, and here you are having frontalis bellies. Now please observe, these two muscles are supplied by the branches of facial nerve. This anteriorly present muscle frontalis is supplied by the temporal branch of the facial nerve, and that which is present posteriorly, that is the occipital muscle, is supplied by posterior auricular nerve of, that is the posterior auricular nerve, which is again the branch of facial nerve. So these are the motor nerves. Towards the side also there can be a muscle, a variable sheet of the muscle, and this variable sheet of muscle that is present towards the side is called parieto-temporalis. It is called parieto-temporalis. This parieto-temporalis muscle is also supplied by the temporal branch of facial nerve. The temporal branch of facial nerve is also supplying this parieto-temporalis muscle, which is extending towards the side. Okay, it is present between the frontalis muscle and the auricularis anterior and superior. It is present between the auricularis anterior and superior posteriorly, and here you have got the temporalis muscle. So it is the frontalis muscle, and here you have got the auricularis anterior and auricularis superior. So in between these, posteriorly, anteriorly you have got the frontalis muscle. Between them you have got this variable tissue of the muscle, that is called the parieto-temporalis. Now if you see, please understand, look at the board. If there is a vertical cut of the galea aponeurotica, nothing will happen. If there is a vertical cut, nothing will happen. But if there is a transverse cut, imagine now somebody had cut it transversely like this, then what will happen? There will be called gaping wound is what you will have. There will be gaping. What do you mean by gaping? The frontalis muscle will be falling forwards, the occipitalis muscle will be moving backwards, and there is a gaping, what you see. Then what will you do? So you will, when you have to suture the wound of the skull, the wound of the scalp, when you have to suture the wound of the scalp, then you call your assistant and you will slowly straighten this frontalis muscle, and you will see that you have pulled the frontalis muscle which had fallen down forwards. Are you able to understand? No, just let us see. The frontalis muscle is a muscle which is arising from the skin and the subcutaneous tissue of the superciliary of this eyebrows, from the region of the eyebrows, the skin and the subcutaneous tissue at the region of the eyebrows, it's giving origin to the frontalis muscle. And if you see this diagram, you will appreciate, I am sure. Now you see here we are trying to draw the eyes, the two eyes we have drawn. Here we have drawn the nose. Please look at the board. Here you have got one muscle, and this muscle is called procerus. This muscle is called procerus, which is responsible for the transverse wrinkling of the forehead. Then you have got lateral to it corrugator supercilii. So this muscle which is lateral to it is called corrugator supercilii. Okay, corrugator supercilii. And a muscle which is present around the eyeball is called orbicularis oculi. So this is the orbicularis oculi. Now please understand, you have three muscles. The medial most is the procerus, lateral to it is the corrugator supercilii, and surrounding the eyeball is orbicularis oculi. If you see this frontalis muscle fibers, they are arising from the skin of the eyebrow, okay, and in that process they are mingling or interdigitating with the fibers of procerus, fibers of corrugator supercilii, and the fibers of orbicularis oculi. Okay, the two frontal bellies are almost continuous with each other in the median line at the root of the nose. Now this is the nose. Here this is the nose, this is the root of the nose. So at the region of the root of the nose, it is continuous with each other, the right and left frontal belly. These fibers are going backwards. Please observe. Now this is the scalp we are trying to draw, and this is the coronal suture. So this is the coronal suture. This is the frontal bone. This is the parietal bones. This is the mid-sagittal suture. Here you are having the aponeurosis coming. The galea aponeurotica is covering the coronal suture. Are you understanding? Just in front of the coronal suture, the frontalis muscle fibers are merging with the galea aponeurotica. So the galea aponeurotica is under the tension because of these two, occipital and the frontal muscles. So if you see this frontalis muscle, if you see what is the action of frontalis muscle? In case of surprise, there is, the eyebrows are lifted up in case of surprise, and in case of fright, there is transverse wrinkling of the forehead. Okay, so this is the job of the this is the action of the frontalis muscle. And if you see posteriorly, the occipital muscles, they are arising from the lateral portion of the superior nuchal lines. Here we said there is external occipital protuberance, and here you got the superior nuchal lines. The lateral portions of the superior nuchal lines, they are giving rise to the origin of occipitalis. So in between the two occipital bellies, you have got the epicranial aponeurosis that is extending. So you have got, this is the occipitalis muscle and this is the occipitalis muscle, the occipital belly. What I am trying to tell is the occipital belly. You have got two occipital bellies and they are separated from each other by a considerable amount of epicranial aponeurosis. Again, this epicranial aponeurosis is present in between the frontal bellies also, the frontalis muscles also, but in the form of a thin median septum. A very thin median septum. In this form, the Galea aponeurosis or Galea aponeurotica is extending in between the two frontal bellies. Are you understanding? So posteriorly you have got a thick sheet that is of Galea aponeurotica between the occipital bellies. If there is a cut starting anterior, posteriorly, if the cut is extending, no problem. There is no gaping. But if there is a transverse injury which is happening to this Galea aponeurotica, it will cause gaping where the frontalis muscle is falling forwards and the occipitalis muscle is going little back. You are understanding? And now we have got the fourth layer, and the fourth layer is nothing but the loose areolar tissue. So here what you have is the loose areolar tissue. The name is itself is suggesting that there is areolar tissue that is present. Okay, the loose areolar tissue, which is the fourth layer. So we have to write the word loose because it is having lots of space. Now please observe, we have talked about emissory veins. Do you remember emissory veins? The veins which are connecting the extracranial compartment with the intracranial compartment. So those emissory veins are present in the loose areolar tissue. They connect the blood vessels, that is the veins which are present in the region of the connective tissue are connected with the superior sagittal sinus or the dural venous sinuses. So here you have got the emissory veins which are present in the loose areolar tissue. Because of the presence of the emissory veins in this loose areolar tissue, we even call this layer as the dangerous layer of the scalp or the dangerous area of scalp, because of the presence of loose areolar tissue, the dangerous area of scalp, because of the presence of emissory veins which are connecting the blood vessels of the second layer, the connective tissue, with the intradural venous sinuses. Okay. Also, there are some advantages because of this loose areolar tissue. There is something called safety valve hematoma. This is very important for us to know. Imagine there is a child and the child is having a fracture of the skull associated with the tear of dura. There is fracture of the skull bone. Yeah, with your permission I am rubbing. So there is fracture of the skull bone and there is tearing of the dura. The endosteal layer got torn, the pericranium here got torn. So the blood will now escape. This blood which is present will now escape into this loose areolar tissue. You know, if there is intracranial hemorrhage, it will start compressing the brain. But there is intracranial hemorrhage but there is a way for the letting out of the blood, as there is a tear in the dura mater and also breakage in the skull. There is breakage in the skull bone. So what is happening now? This blood will, the blood which is flowing out or leaking out, the intracranial hemorrhage will go out into the loose areolar tissue and start filling it. It takes lot of time for the child to develop the cerebral compression. The signs and symptoms of cerebral compression in such a child are not immediate, even though he is having injury, because there is a fracture of the skull bone with the tear of dura mater, resulting in escape of this blood into this subeponeurotic, into this loose areolar tissue. Sometimes CSF can also escape into this space, into the loose areolar tissue. You can have CSF also escaping. That time it is called cephalohydrocele. Cephalohydrocele. So what is this cephalohydrocele? Wherein you are having the CSF escaping out into the loose areolar tissue, okay, and it is giving time for the doctors to act. You know, sometimes by the time patient reaches the hospital from the site of road traffic accident or injury, the patient is brought dead. But in such cases where there is fracture of the skull associated with the tear of dura, this venous blood and the intracranial hemorrhage, whatever is happening, is slipping away into your loose areolar tissue. So there is no compression of the brain. This is called the safety valve hematoma. But if CSF is getting accumulated, it is called cephalohydrocele. Okay. Now the last but not the least is P. Okay, the fifth layer P, and that is the pericranium. So you know the bones are having periosteum. So like that you have got here the fifth layer. I am just drawing with a red color for you to beautifully see, and some space I am leaving here, please understand. So here is the pericranium. So now here you are having the pericranium, the fifth layer. This is the pericranium, which is nothing but the periosteum. It is acting like the periosteum, which is called the pericranium. Please see, the pericranium dips into the sutures and it is a continuation with the endosteal layer. The pericranium, which is present above the outer table of the skull, it is dipping at the region of the suture and it is continuous with the endosteum of the skull. Please understand, sometimes if there is accumulation of blood that is present under the pericranium, this pericranium is present covering the bone loosely. The pericranium is present covering the bone loosely, so you are able to see some space. The blood which gets collected here will take the shape of underlying skull bone. Imagine if you see the parietal bone of the skull, it is little convex. Above that you have got the pericranium. So when blood is getting collected here, so you will see, imagine if this is the parietal bone. Please see, this is the parietal bone. Okay, at that sutures, now you know this is the mid sagittal suture. So this pericranium is dipping into this suture and it is continuous. This is the outer table, this is the inner table, this is the diploe, right? So here it is continuous with the endosteum. What? This pericranium is continuous with the endosteum here. So if there is collection of the blood which is present beneath the pericranium, then the blood collection will take the shape of the underlying bone, which is called cephalhematoma. This is called cephalhematoma. Are you understanding? Here you are getting cephalhematoma. What is cephalhematoma? The blood which gets collected underneath the pericranium, because pericranium is loosely covering the surface of the bone. No doubt it dips at the site of sutures, it dips in and it is continuous with the endosteum or the endocranium. So the blood collection will take the shape of the underlying bone that is present, especially seen at the region of the parietal bones, and that condition is called cephalhematoma. And please understand, sometimes when the baby is delivered normally through the birth tract, if there is any obstruction or if there is any delay in the labor, the venous return is interfered. The venous return in the newborn baby, the baby is just coming out of the birth tract, that is interfered, and that causes caput succedaneum. So there is a clinical condition called caput succedaneum. This is because of the interference. This is because of the interference with the venous return in the baby during its delivery. So that time what happens, there is a boggy swelling, the head is totally, it looks abnormal when the baby is born, where you see there is a bump, there is a boggy swelling, sometimes you see it's like a bump more towards the occipital region, at the region of the external occipital protuberance, you're understanding, and that condition is called caput succedaneum. What is the treatment for caput succedaneum? You need not worry, within 10 to 15 days it will become normal, absolutely it will become normal. The head was coming out of the birth tract and then there was some obstruction to its venous return, that's why it resulted in caput succedaneum. Also, I forgot to tell you when I was talking about hairs, about an injury which is called avulsion injury of scalp. Now what is this avulsion injury of scalp and how it will heal? It will heal very well if you do the trimming and suturing. You want to learn about the avulsion injury of scalp, then you have to see the blood supply and nerve supply of the scalp, where we have explained in detail about the avulsion injury. Thank you. Now let us quickly revise about the scalp. What is the definition of the scalp? The soft tissue which covers the calvarium or the skull cap is called scalp. Anteriorly, the scalp is extending to the level of the eyebrows or the superciliary arches, posteriorly up to the level of external occipital protuberance and the superior nuchal lines. To the sides, on either side it is extending up to the level of zygomatic arch, where it includes the temporal region. Now coming to the scalp, the different layers which are present are skin, connective tissue, aponeurosis, loose area tissue and pericranium. The first layer is the skin, which is having lots of hairs. Along with them you have got sebaceous glands and sweat glands. Because of the numerous sebaceous glands that are present, it is a common site of sebaceous cysts. If you take the hairs, they are showing the nutritional status of the person. They are basically structures which are made up of keratin or protein. In case of Kwashiorkor and marasmus, the hairs are dirty brown in color, they are showing the flag sign, and normal number of hairs that are present are 1,20,000 to 1,30,000. 10 to 20 or even up to 100 hairs can fall off daily, and that is normal because there is concomitant replacement of these lost hairs. There are certain conditions, chronic illnesses, which are going to cause hair fall. Even some chemotherapies for cancers, when some injections are given, medicines are given, they cause hair fall or hair loss. And then in men there is baldness which is seen. Sometimes it is genetic also. Coming to the second layer, which is the connective tissue, that is fibrofatty layer which is present. The fibrous stroma that is present in this second layer, it is having blood vessels attached to it. So if there is any scalp injury, if there is any injury to the scalp or any cut, that will bleed profusely. The wound will bleed profusely because the blood vessels are not able to retract due to their attachment to these fibrous strands. If you want to stop or control the bleeding, then you have to apply pressure by the tips of your fingers. Then you have to do a very tight bandaging of the head above the eyebrows and above the ears. You have to tie the bandage with putting a lot of cotton and the pressure bandage to be applied so that we can control the bleeding. Otherwise, there can be dangerous hemorrhage that can happen. Then the epicranial aponeurosis is seen as a third layer. The first, second, third layers, that is the skin, connective tissue and epicranial aponeurosis, they all move as a single unit. So they are also called as scalp proper. They are also called the surgical layers of the scalp. The epicranial aponeurosis is having anteriorly connected with the frontalis muscles and posteriorly with the occipital bellies. The frontalis muscle, if you observe, it does not have any bony attachment. It arises from the skin and the subcutaneous tissue of the eyebrows, while it is ascending up and going backwards to merge with the epicranial aponeurosis just in front of the coronal suture. The two frontal bellies, they come in close approximation medially. So we call it the frontalis muscle, okay, with the right and left bellies of the frontalis muscle. And in this process, the frontalis muscle, it is mingling or interdigitating with the procerus, corrugator supercilii and orbicularis oculi muscles. The frontalis muscle will help us to elevate the eyebrows as in case of surprise, and the lower portion of the forehead can show transverse wrinkling. The transverse wrinkling in cases of fright, which is again considered to be the action of frontalis in association with procerus and corrugator supercilii. And if you see the occipital bellies, which are arising from the lateral parts of the superior nuchal lines, they remain separate, and the epicranial aponeurosis is seen extending between the two occipital bellies. And there is one variable sheet of muscle that is called parietotemporalis. The parietotemporalis is present between the muscle frontalis and auricularis anterior and auricularis superior. These frontal bellies are supplied by temporal branch of the facial nerve, and the occipital bellies are supplied by the posterior auricular nerve of facial nerve. The muscle parietotemporalis is also supplied by the temporal branch of the facial nerve. Now here we have forgotten to learn about a clinical condition called black eye. Now what is this black eye? So black eye is a condition because the frontalis muscle is not having any bony attachment. The collection of the fluid, maybe blood, maybe pus, whatever it is, which is present here in the loose areolar tissue, will descend downwards due to gravity, due to lack of bony attachment of the frontalis muscle. It will gravitate down around the eye and it causes periorbital ecchymosis, which is called as black eye. So what is that? Peri means around, orbital ecchymosis, periorbital ecchymosis, which is called the black eye because of the frontalis muscle not having any bony attachment. Okay, then we have got the fourth layer, which is called the loose areolar tissue. It is also called the dangerous layer of the scalp or dangerous area of the scalp because of the presence of emissory veins. Now we learned emissory veins, which are valveless veins that are connecting the extracranial veins with the intracranial dural venous sinuses. Okay, so the infection that is present here in the region of the scalp, that is which is extracranial, can become intracranial now. Okay, and that's why it is called as the dangerous area of scalp. One advantage because of this loose areolar tissue is the safety valve hematoma. So whenever there is intracerebral hemorrhage and if there is fracture of the skull with the tear of dura mater, the blood which is present or coming out in this intracranial hemorrhage will not collect in the cranium and compress the cerebrum. It will escape through this tear and the fracture line, and it will get accumulated in the loose areolar tissue. So the cerebral compression is not seen the cerebral compression does not start quickly. There is some time given for us to restore these patients. By the time this entire loose areolar tissue will be filled up by the blood, and then only the cerebrum will get compressed. So there is some time to the neurosurgeon given, okay. So there is good recovery of the patient. That's why it is called safety valve hematoma. Sometimes the CSF can get accumulated in this loose areolar tissue, and that is called cephalohydrocele. Now coming to the fifth layer, the fifth layer is called pericranium, which is nothing but the periosteum of the skull bones. This pericranium is loosely attached to the surface, loosely attached or loosely present over the surface of the bone, but at the region of sutures, it dips into the sutures and is continuous with the endocranium. If there is collection of the blood beneath the pericranium, this subpericranial collection will lead to the formation of one bump with the shape of the underlying bone, and this is called cephalhematoma. Okay, this is called cephalhematoma. And coming to another condition called caput succedaneum, this is because of the interference with the venous return during the birth of the baby when it is coming out of the birth canal. So if there is any disturbance in the venous return or interference in the venous return, it causes a bogey swelling which is very large in size, and it is causing the facial disfigurement, but this is only a temporary state. Within 10 to 15 days, it will set by itself. It will become normal. We need not worry, and that condition is called caput succedaneum. And coming to the avulsion injuries of the scalp is extremely vascular, okay, and we will be going in the next video about the avulsion injury after we discuss the blood supply of the scalp. Thank you.